Good afternoon again, United TV with Bariatric Friday. Dr. Irgau is with me in our studio. We had a two-week break where we had with the trips. In some cases, but I feel like I can still do the session there, but having a little bit time off helps with our cycles as well. So then we have. Because we are covering 13 to 15 topics. So it works like when I was checking it, it kind of works all together. Now today, we actually are gonna spend a little bit more time on bariatric revision surgeries. Now in our different sessions, we mentioned revisions, but not as much, we didn't spend as much time on those. Now, revision is one of the really important part of what we do day to day, because every consult who comes to us today, it's not just for the initial bariatric surgery. Now, when we discuss this topic, I sometimes kind of trying to process this from the devil's advocate standpoint. Hey, like, why did it fail or did it not work? So, and then we were talking about this the other day. 20 years ago, these phones, can you see, was not available, right? Sure. Today, This is the 15th. I think John ordered me the 16th. Hopefully he's watching. So we didn't have this, right? So you weren't using EMR. You weren't using the same technology. We didn't have the same medications. We didn't have the same techniques. We used to keep patients in the hospital for minimum 1 or 2 days. Now today, 99.9% of the patients are discharged from 6 hours of their operation, right? So the reason I'm saying all this is because I don't want some of our patients to understand this in a different way. The efficiency is there, but the techniques are changing. And I guess one of the main reasons for the revision is what we have done before, like gastric sleeve. We were not doing it 20 years ago. Now I'm going to stop here because this is your expertise. So that if you can give us the background on the bariatric revision surgery from the clinical side, and then we'll go from there.
Absolutely. So I'm actually very happy that we are doing this session, Kemal, because we do get a lot of questions on this topic from our patients. We talk about revisions very often, and the question comes, what is a revision? And, if there is no, clear explanation, people will have their own interpretations as to what a revision is. Essentially, when we talk about surgical revision in surgery in general, it means that the surgeon would revisit the area of the surgery and undertake an additional or a repeat procedure to enhance the previous procedure or to fix something that has happened since the procedure has occurred. That's why we talk about revision, essentially, right? So this can occur, for instance, in somebody who has had a hip replacement surgery or a knee replacement surgery, and they've used their artificial knee for a while and something has happened and a revision may be needed. That may be because something needs to be fixed about the surgery, but also because the patient is not the same patient that had the surgery previously. So as you correctly say, time passes and surgeries may require innovation, right? Because things have changed, but also the patients themselves may be a different patient with different needs that require a different type of approach. So revisions are very, very well known in the surgical realm, and they should be no different when it comes to bariatric surgery. Which means that very often patients who have undergone a surgical procedure and a change that is going to take them through their lifetime may require a revisitation of that procedure, again, either to address a complication may have occurred later, right? For instance, an example would be a patient who's had gastric bypass, for instance. Now that patient, despite all our advice, encouragement, and counseling, for instance, that patient may have started smoking. And one of the things that can happen when patients smoke after they had gastric bypass is they can develop an ulcer at the connection between the intestine and the stomach, right? Gastrojejunal ulcer, it's called. That ulcer is treated generally medically, which means we would give the patients medications, anti-acid medications, and that takes care of the problem. But there are a number of patients on whom the medical treatment may not be sufficient, and we may have to go in surgically remove that ulcer and reconstruct that anastomosis. That is a type of revision surgery where we are revising that connection, that anastomosis. So we are doing a revision. Or it could be a patient who's had a gastric band, for instance, who may have done well up to a certain point, but because of the actual limitation of the scope of the gastric band, they may not be losing as much weight as they need, or they may have developed complications of obesity that require a much more powerful procedure, in which case we do a revision surgery whereby we go in, we remove the gastric band, and now we perform a more powerful procedure like the gastric sleeve or the gastric bypass. And so revisionists have different purposes and are undertaken very commonly. Right? The important issue, obviously, is that revision certainly, based on the knowledge that is required to understand when a revision is required, but also based on the technical experience that is required, require a surgeon who is seasoned or she is seasoned with these procedures because they require a different set of skills in terms of addressing these issues. And why is that? Well, fundamentally, this is because the surgeon now will be working in an area of the body that has been operated on already. It's not what we would call virgin territory, where the anatomic landmarks are set and present, and the surgeon can follow those landmarks to navigate the area. Now, surgery has occurred in that area, so the anatomy is distorted. It's not the original anatomy. Moreover, the tissue that has been operated already or manipulated already becomes scarred tissue. So its manipulation is going to be different. So there is more potential for complications, in which case, that's why we talk about surgeons being experienced when they approach this type of surgery. So that's really to give an overall view of what we mean by revision and what generally is the scope of revision, that is to address a potential complication of obesity or of the procedure, or to address, to provide even more powerful procedure than the one that the patient has had originally.
So, from the statistics, almost, I would say, easily 87 to 90% of the revision surgeries that we do today, they're from left band to either band to sleeve or band to bypass, right? So there's others that we do, but that's not as common. Now, we know that left band was good for its time, but it wasn't the most effective way. So, like, it may be someone with it on the lower, with the morbid obesity range on the lower side. For someone who's younger, who's making a lot of changes, it may be okay for them, who has a lot of disciplines, but it's not gastric sleeve and it's not gastric bypass for sure. So, and knowing that our habits, if we don't adapt and make changes, the stomach is still there. So with the band, all we do is just making it smaller, the top portion, right? So like the stomach, let me just squeeze the top and put the band. So just from the, like, I'm not a surgeon, I can't just explain it in a really bad way.
You're great.
So, and then that part can start doing the same thing that the other part was doing before, and it can become bigger, expand, and therefore, unless we make those changes, because we have a lot of patients who have band who were very successful.
Absolutely.
And then there are actually some patients who want band to be removed because they are actually in their ideal BMI range. So there are those examples, but we are talking about those who are not able to get to the point of losing enough weight, or that this, again, band not being working at the best efficiency. So the same thing is, when we have medical weight loss drugs, it's great that we have these tools, but the drug that we have 4 years ago is not as good as the one we have today. But even the ones we have today, unless you keep taking them, you are not going to see a permanent change unless you make drastic changes on the lifestyle and diet part of it. So interesting enough, Dr. Gasso, as you know, we shared all these in our session. So I was in Turkey. The first week was a vacation. Like every other time, I rotate, so I don't take time off. But this time I did. So 3 months, no sugar, no ice cream, no bread, no nothing. About the face. So I can see some of the people in the office say that, hey, he's lying. Yes, there were some exceptions. 97% I was clear. So yes, I had a couple of McDonald's, fine. I had maybe 2 milkshakes in 3 months, fine. But 97% I was not taking, even my coffee, no Starbucks, nothing. Not like I was protesting Starbucks, just like it was 200 calories that I can actually, replace that with 0-calorie Turkish coffee, which is better. So now, as soon as, and then this time also I didn't play tennis. One of the other things that I did, every time I'm on vacation, 1 hour, I would play tennis every day. And you know what happened? I gained weight after 1 week.
Yeah.
So that means all those changes that I have done, the discipline that I had, can be wiped out in 1 week. And today is like 3 weeks after that time, or 2 weeks, and just feeling myself again because I'm back doing certain things. Not eating as much, but on vacation, like there's ice cream every day, 3 times a day. It's free. So like, hey, you want ice cream? Like, no, I don't want. You should have it. And there's drinks, there's this, there's that. So this is kind of like why morbid obesity is extremely complex, and it's not really easily understood even by some clinicians, because it changes, it varies from one person to the other. So now, Dr. Ergau, before we go into more specifics, can we talk about the reflux? Because we kind of use that as it's kind of like maybe side effect of some of the, not side effect, the patient has the conditions, but with some situations, if they already have the bariatric surgery of some type, they may go to a reflux, and I want to make sure that we cover that in the revision side.
Absolutely. So heartburn or reflux is a very common condition in general, right? And it tends to be more common very often after the application of certain bariatric procedure, particularly the gastric band and the gastric sleeve. Not universally, but certainly more common. And in the vast majority of situations, heartburn is actually managed by dietary adjustments as well as utilization of medication, either as needed basis or on a regular basis. But there is obviously a proportion of patients on whom these measures are not sufficient, right? In which case we can offer surgical solutions, right? So for the gastric sleeve, for instance, surgical solution for heartburn that is intractable and ongoing would be to switch the gastric sleeve into gastric bypass, which by its nature has really an anti-reflux anatomy, because the vast majority of the stomach.
Can you just repeat that again, like the last 20 seconds?
Yeah, absolutely. So if you take, let's compare the gastric sleeve and the gastric bypass. Okay, with the gastric sleeve, there's a food pipe, right? The portion of the digestive tract that is in our chest is still connected to the whole length of the stomach. Right. Although the majority of the stomach is removed, the length of the stomach is still connected to the right. Which means that acid from that stomach can still potentially travel backwards into the food pipe and irritate the lining of the food pipe, which is not supposed to interact with acid. That is the key. So remember, we have a lot of acid, very strong acid in our stomach, but our stomach has a lining that is purposely constructed to resist acid. That's why we don't feel that, right? But the food pipe, its lining is not constructed to resist acid. Therefore, when acid travels backwards into the food pipe, that creates problems, including the symptoms that we get, but also irritation of the lining of the food, right? So if you take the gastric sleeve, what we've done is we've taken a big portion of the distensible portion of the stomach, and we've removed that, so the stomach is stiffer now, right? Which means the pressure inside that stomach can go up very easily and quickly. And that pressure can displace the acid in the stomach upwards into the food pipe, where the pressure in the chest is much, much lower, right? But if you take gastric bypass now, you have the stomach that is amputated very high up. So the lower portion of the stomach is totally separated from the upper portion of the stomach, which generally has no acid holes or has very, very little acid. Therefore, there is no potential for the acid from the lower stomach to travel back up into the food pipe, which means that if you change the gastric sleeve into the gastric bypass, you are automatically relieving the food pipe from the potential of being exposed from acid. That's why a surgical treatment of acid reflux on somebody who has a sleeve gastrectomy would be to change them to gastric bypass. Now, how often does that happen? Not very often, right? But because we have a lot of patients, very often we seem to be doing a lot of revisions. But really, clearly, the vast majority of patients who had the gastric sleeve do not require a revision to this.
Sure. Now, the term heartburn is, I think that's one of the American ways of making things more difficult. There's no heartburn, so your heart is not burning, right? So it's just reflux, like that.
Yes, that's actually a better term, right? Because heartburn implies almost as if the heart is important.
Right, so it has nothing to do with that. Now, but that's, again, I see that maybe the second most common that we do under the revision is
second most common, but way below the first most common, right?
Oh, yeah. So
way more.
There's a huge, like 87%, and maybe this is 3 or 4%.
Absolutely, absolutely. So let's talk about the gastric band, because you raise a very important issue. You say that the vast majority of our revision surgery involves actually removing the gastric band and switching it to something like the gastric sleeve or the gastric bypass. And why is that? Well, the real answer for that is twofold. First of all, because the gastric band is a device. It's a device, and that can be removed. And that was actually the very characteristic of the gastric band that appealed to people. People like the idea they could have a device that could be taken out as well, right? That permanence of a gastric bypass or the gastric sleeve was not there. That was appealing to a lot of people, that they wanted the band for that.
Because as soon as you tell people that you are going to cut their stomach, that becomes
absolutely. And at that time, in fairness, at the time in which the gastric band was very popular, was also the time where the only other alternative we were offering was the gastric bypass, which is a step up, much higher step up in terms of complexity, but also long-term implications of the changes that the patient was incurring when they got gastric bypass. So needless to say, a lot of patients chose to have gastric bypass, right? So the fact that it's a device that can be removed really means that there is much easier time in doing a revision. You can say, okay, let's remove the band and change to something else to address two problems, right? One could be a problem of inadequate weight loss or weight gain. That can happen with the gastric band. We know that in the realm of bariatric procedures, the gastric band is a relatively weak procedure when it comes to weight loss. So if you have somebody who requires extensive weight loss, the gastric band could take them just so far, right? After that, they may require something more powerful. So that's one issue with the gastric band. But the other issue with the gastric band, obviously, as a device, it requires really a very, very narrow window of adjustment of its tightness. So the amount of fluid you need to fill the band to get the person to feel satisfied and to feel not hungry is really very close to the amount that would cause the band to be too tight. So that window is so very narrow, and it could change from day to day, which means that patients may feel, okay, I have the good restriction now, I'm not hungry, I'm not eating too much, and then 3-4 months later, they could be having problems swallowing, obstructive problems that make really life miserable and quality of life not good. So that back and forth between not being hungry or not hungry, but having restrictions with vomiting, and vomiting that can occur in the most unpredictable situation, which means that patients will be at a restaurant eating, and then suddenly they have to go rush to the bathroom because they can't swallow things. So the band really becomes very inconvenient in this way, but also that back and forth between it being too tight or not tight can lead to an exasperation of the patients, right? Where the weight really doesn't become a good focus by itself, and therefore they end up gaining weight. So it's not surprising that a fair number of patients who have the band, who've had the band for many years, decide at some point, look, I need a different approach. And the good thing is we can offer that approach. We can offer that approach because we have options that are less invasive than the gastric bypass. For instance, we can do the gastric sleeve. Also, the gastric bypass by itself is also an option. And these procedures, although more complex than the first-time procedures, can be undertaken with safety, particularly in very experienced centers like ourselves, right? Our center has a lot of experience with the gastric band, it has a lot of experience with the gastric sleeve, has a lot of experience with gastric bypass. We're operating in an area of the body which is the same, right?
Our nurses, they're the most probably knowledgeable in bariatric.
So we can offer revision surgery, these repeat surgeries, even in an outpatient setting, and we do it very often, essentially. So we have to get out from this mentality that bariatric surgery should be treated differently than any other surgical treatment, right? When a patient has a procedure for cancer and they require a revision of that procedure, we don't tell them, oh, you had one procedure, we cannot do it again. It's the attitude of certain, third-party payers who, for instance, with a straight face would say to somebody, you can have only one bariatric procedure for life. I mean, it doesn't make any sense at all, right? We are not doing, we're not offering a person something that they have to really earn. This is a disease that we're treating, okay? And
time to time, we see that even with our people in our organization.
Absolutely.
Did he really do that? I'm like, hey, you're not double guessing. I mean, second guessing what surgeons say, what cardiologists say, what EGD report is saying. So just because if you are doing something wrong, that mentality, you are absolutely right. That's just here.
The mindset has to change.
No question. So someone who has the band for 15 years, right? The anatomy of that stomach, how different that is if they didn't have the bariatric band, lap band.
So that's a very important question, because remember, one of the qualifications of the gastric band was that it was a reversible procedure. Well, yes, it is reversible because the band can be removed, but the anatomy is not exactly the same that it was before. And that is because the presence of the band does cause scar tissue. So the tissue around which the band was sitting has developed a fair amount of scar tissue. And that scar tissue is obviously something that we have to take into consideration when we are going back to do another procedure. The anatomy is not exactly the same. The thickness of the tissue is not exactly the same. If I am using a particular type of device to cut and close a portion of the stomach, I have to take into consideration that that portion of the stomach has had scar tissue, and therefore the choice of the device may be different from the one I would choosing, for instance, on a stomach that has never had scar tissue. So the stomach is definitely different. Yes, the sequence of the organs has not changed. The food pipe, the stomach, and the intestine are in the sequence that they were naturally at. But the actual area where the band was, if you actually look at it at surgery, you see it thickened, you see it has different color, and you see it distorted in its position as well. You see it attached to other organs that normally it wouldn't be attached.
So there's a
because the scar tissue has
wouldn't be there.
Absolutely, right? Absolutely. So we have to have knowledge of all that for us to be able to take care of it safely. And we have an excellent protocol for taking care of that. So we've had many patients who've had the band, for 15 years, sometimes even 20 years, who were very satisfied with the band, but understood that the band has run out its course and it was time for us to do something different. Beyond that, there are situations in which the band could slip, it could change position, and that creates symptoms and problems that would require addressing. And we go and address that by removing the band and then giving a different anatomic variation of bariatric surgery, be it a gastric sleeve or the gastric bypass, for the person to not to gain weight and resume their weight-free life again successfully, for the rest of their life.
So just so that those who are watching this today, for them to kind of better understand. So when we have a patient who's coming for the operation, they may not know what they're coming for because they usually have weight gain or they have some discomfort with the band, if it's from the band to one of the other surgery types. So the way that the process works for us is just like if they were just first time having surgery, their first consult with the surgeon. Depending on their each individual situation, surgeon may want some clearances and they may not want all of them altogether because these patients are already educated on certain things, but we may replace some of the clearances. We may need some clearances, such as cardiology, bariatrician, and based on their sleep apnea situation, if they are using a CPAP machine or not, we may actually get those. But the process usually is a little bit shorter than the actual initial one.
Absolutely.
So that once that happens, then 99% of the time we actually remove the band. So then they're actually not two-stage surgery, but two-stage from the time standpoint. So we have to remove the band, and then same day they are usually discharging in 4 hours for the band removal, averaging it's less than the actual initial bariatric. So then 3 months,
2 or 3 months,
2 to 3 months, we would wait for the second procedure. So that's where we would say, okay, here's a band to sleeve or band to bypass, whatever, depending on comorbidities, depending on patient's age. Diabetes is important in that, still similar criteria that we have for the selection of the surgery type. So, but then they would be actually almost done in a similar amount of time that they can be done for the initial surgery. That takes about 3 months, and if we do everything properly, we can finish this in 3 months from consult to the second surgery.
Absolutely, right? Absolutely. So one important, comment to make on what you say is that revisional surgery that is repeat surgery that is undertaken on an area that already has been operated, carries a high level of risk. There is no question about that, right? So because of that, when we are approached by a patient about doing revision, first of all, surgical revision doesn't necessarily have to be the first option. It has to always be on the table as something that, if needed, needs to be undertaken, but it's not necessarily the first option. For instance, a patient who had a BMI of 40 and now they have a BMI of 31. They're having complication of the band and they want the band removed, but they want a different procedure. Well, we may say, look, you're at the BMI of 31 right now. The band is out. We don't have to necessarily go to a different procedure. Maybe we can try medications to get you down to a little bit from where you are. Maybe that may be the better option. So surgery doesn't have to be the first option always, right? Second, the other thing to consider is because the potential for complication is higher, and because we really, the best way to minimize complication is to prevent. Really, that's the best way. And one of the ways to prevent or minimize this complication is to reduce the amount of scar tissue. And how can you do that? Well, by taking the band out first and let things heal, let the scar tissue mellow. And it's amazing how different the scar tissue looks like when you're immediately taking the band out and when you revisit the area, let's say 2 to 3 months later.
This was one of the first that you taught me early on.
Absolutely.
And when you say scar tissue, if you're not a surgeon or clinical person, I guess
It's difficult to conceive that. Absolutely.
I remember that back in 2012. And actually, yesterday I was explaining that to Alp because there was a patient where we did do the replacement, the removal and the replacement at the same time.
Okay.
And he was asking why that happened. It's because it was a port tissue. Remember that patient?
Right. That is different.
That was an old band, and then the port was not available, so that we had to replace.
Yeah.
But then I was telling him about the scar tissue, and I just explained, hey, so this is pretty impressive because it was 12, 13 years ago when you actually went through that. So that's one of the, I think, risk factors or making things more complicated for us if it's not healed properly.
Absolutely. Absolutely.
So now you have a flight. So, and then I promise you that I will let you leave here by 3:40. So it's 3:35.
All right. Well, thank you.
So just remember, there's a fine at Philadelphia Airport if you go there too early. 1 hour, $100 fine. So you cannot be too early. So thank you for joining us. Next week,
It's great to be back.
Dr. Gail Wynn is going to be with us. And then you'll be back after that. So then, again, thank you for watching us. Thank you for coming here every Friday. So we'll be back with Dr. Wynn next week.
Absolutely.
All right.
Thank you.